Shabina?
Oh,
There's a timer. I can't listen to the music.
I guess we are supposed to be starting with that counter. Hi, everyone, and I extend my warm welcome to all of you for the first Kerakonnect of this year. This year, we have planned few different formats of involvement of our members, including some journal clubs, including some other non-cornea related stuff, including some other formats which we will keep secret and will keep revealing it to you. But the Kerakonnect is something which is sacrosanct, and we found that this is something which connects all of us, and all our members loved Kerakonnect, and we had to continue Kerakonnect. And this year, to start with, who else can carry it forward but our beloved Vikas, who left last year's Kerakonnect with Keratoconus, and then we had promised that we'll complete it with the peripheral ectasia, and hence Vikas decided to take up this first Kerakonnect of this year as the Kerakonnect on peripheral ectasia. Without further ado, I would invite Vikas to take forward the program. Vikas, all over to you.
Yeah. Thank you so much, Himanshu. And I again welcome everyone here for our next Kerakonnect. And this time we have already shared what is the format. We have already shared what are the topics that we are going to cover. My slides are visible now?
Yes.
So today we are going to cover 3 topics in Keratoconus: post-lasik ectasia, PMCD, and Hydrops. And for that, we have a fantastic panelist. The format of this Kerakonnect is panel discussion. So we are going to discuss a lot of things, and we have divided into 3 subsessions. And the panelists we have, you can see we have Dr. J.K. Reddy, very experienced, more than 2 decades of experience in cornea, as well as in refractive surgery. I'm sure he'll be a great contribution. His comments will be a great contribution. Our beloved Himanshu Matalia, very popular, and I'm sure that his comments will be very useful. True academician, Dr. Radhika Natarajan from Shankar Netralaya, Chennai. Dr. Sunita Chaurasia, she has a lot of work in cornea, in Hydrops, also in keratoconus, endothelium, from Prasad Eye Institute. Ashish, he again has fantastic experience in refractive surgery and cornea and keratoconus. Dr. Ashish Nagpal is from Nagpal Center of Cornea and Wavefront from Ahmedabad. Rishi, we all know him. Is always present, a dynamic cornea surgeon and a director and senior surgeon from Swaroop Eye Center, Hyderabad. We are 3 moderators for each session, Sharon and Purvasha. I'm going to take up post-lasik ectasia. Followed me, Sharon will take up PMCD, and it will be followed up by Dr. Purvasha Narang, who will be discussing Hydrops. We have a review literature team also led by Dr. Depriya. So without wasting any time, we'll start with our first session. So what we have done is we have 2 primary discussions for each section. Post-lasik ectasia, we have Himanshu and Ashish. For PMCD, we have Rishi and Dr. Radhika. For Hydrops, we have Sunita and Dr. J.K. Reddy. So to start the thread, we'll use cases. So these are the cases, and we are going to present first 2 cases. They are already recorded version we have, and the presenters are also available here. So let's start with our first 2 cases by Smriti Dani and Rajat Jan. Shabina, can you please start the case?
A 28-year-old female with history of spectacle use since 18 years presented to us for refractive surgery. There was no history of contact lens use, any systemic illness, and refraction had been stable for over 5 years. Refractive error in right eye was minus 5.5 sphere with minus 1.5 cylinder at 180 degrees, and left eye was minus 4.75 sphere with minus 0.75 cylinder at 180 degrees. Pentacam showed symmetrical bow tie appearance on anterior elevation map in both eyes, with the thinnest pachymetry of 521 microns in the right eye and 516 microns in the left eye. There was no abnormal posterior elevation. The patient underwent both eye wavefront guided microkeratom LASIK with temporal hinged flaps with a flap thickness of 100 microns. She had an uneventful postoperative course with an uncorrected visual acuity of 6/6 in both eyes at 1 week and 1 month post-op. 3 years after LASIK, the patient presented with complaints of blurred vision in the right eye since 3 months and a history of chronic eye rubbing. Refraction showed a visual acuity of 6/60 in the right eye, improving to 6/9 parts with a -3 diopter sphere, and 6/6 unaided visual acuity in the left eye. Pentacam showed central ectasia in the right eye, whereas left eye showed no evidence of ectasia. The patient underwent right eye transepithelial PTK with corneal collagen cross-linking. PTK was done at 54 microns ablation depth in a 5 mm ablation zone centered around the coordinates x-0.2 and y-1.2. The patient was also started on oral vitamin D supplements along with topical cyclosporin 0.1% eye drops and was advised to avoid eye rubbing. 1 year post PTK C3R, the pentacam showed stabilization of the central cone along with flattening and a refraction of 6/18, improving to 6/6 with minus 1.5 sphere in the right eye. Left eye pentacam as well as vision were stable. This has been maintained up to 2 years of follow-up. This case highlights that post-lasik ectasia can develop even in patients showing normal preoperative corneal tomography, and chronic eye rubbing is a significant risk factor for the same.
Thanks so much. Can we have the second case also?
Good evening, everybody. I will be presenting my case now. So our patient, a 26-year-old female, presented to us on 6th of April 2019 with decrease in vision in both the eyes for the past 2 and 3 years, which she noticed that it worsened after pregnancy. She had a history of uneventful LASIK surgery done in 2012, and she told me that the vision was good after surgery. She was also adamant on spectacle-free options because of social issues, if possible. In the right eye, she had an uncorrected visual acuity of in around 3 meters and a best corrected visual acuity of 6/60, improving with the given spherical correction. The K reading was 47.5 and 50.5, and the K max was 57. The steepest K value was 57. The topography is mentioned, is shown in the figure, and the thinnest pachymetry was 433 microns. The findings were corroborated in the Belen-Ambrosio enhanced ectasia chart. In the left eye, the vision was 6/36, improving to 6/12. The thinnest pachymetry was 499. The topography showed a mildly irregular cornea, but the steepest K was around 45.8. The Belen-Ambrosio map showed early steepening in the posterior curvature. The case is open for discussion.
Thanks so much. That was done, Rajat. This was all, no?
Yeah.
Okay, thank you so much. So we have seen 2 cases of post-lasik ectasia which were managed by cross-linking as well as TGPRK. So to start the discussion, may I ask you, Himanshu, what do you think? So can you just highlight how the ectasia in post-lasik, these cases and K-conus, how is it different? Or do you have something called as stable post-lasik ectasia? So if somebody sees post-lasik ectasia, what does that mean? Should we straight away go ahead and cross-link it, or what is the behavior? How it is different from a routine keratoconus ectasia?
So Vikas, not just histopathologically, but even if you look at temporal wise, very typically the post-lasik ectasia are late onset. The age group is also much later versus what we have in keratoconus, which is much younger age group. And we know the inflammatory process starts from the surface, and then we are getting that issue. Now, in post-LASIK ectasia, we know that the LASIK flap as such biomechanically is not going to give support to the eye as much as we have a strong anti-stroma in keratoconic eye, which normally would give. So by the time where post-LASIK ectasia occurs, there is significant biomechanical damage which occurs on the posterior stroma, and the ectasia starts in, and when it starts showing up on surface, it's already there, and there is absolutely no point any further to wait that can we wait for it to stabilize or not. Now, if there are known factors which are possible to correct, and we can stop post-LASIK ectasia, I guess in the same way we can prevent the post-LASIK ectasia also. But we also know that the incidence of post-LASIK ectasia is so low that we still fail to understand the true high-risk factors for post-LASIK ectasia. So whatever hypothesis has been given about the risk factor of ectasia, you would have done many of such kind of cases without having ectasia. So the interesting part is that, yes, the incidence is very low, and hence we really don't know how actually it happens. So the time we see a post-LASIK ectasia, further waiting on that and hoping that it will stop progressing and it will get corrected would be actually futile exercise. So I do not believe that you need to wait for progression to be seen in post-LASIK ectasia, and it's certainly not keratoconic eye.
So which means that, like in keratoconus, we sometimes, suppose the patient comes in 22 years, 23 years, we tend to see whether it is really progressing, and then we think of advising a cross-linking. But you are saying that, if you see a post-LASIK ectasia, there's no point in waiting. We can go ahead and cross-link to ensure that whatever we have, we can contain. Ashish, do you feel that while we had seen in our first webinar also that age, allergy, hormonal influence, they have a strong correlation with the progression of ectasia in routine keratoconus? So do you feel that the same thing in your practice? What do you feel? The same, would you like to see those prognostic indicators in post-LASIK ectasia as well?
Yes, in a way, indirectly, yes, they do. But just to take a step backward, like Dr. Himanshu pointed out, we don't really understand the risk factors completely. But in my mind, broadly, I see there is ectasia in patients, number one, whose abnormal topography or who are almost like a FFKC, a form first, and has been missed. So those are the ones who may develop ectasia faster, earlier. And there are cases like the one which you showed in which everything is apparently normal and they still develop ectasia. So broadly, I think these are the two factors. Apart from the third one, which earlier that the keratome would cut a thicker flap or something, which I think is less frequent nowadays. So apart from this, so these are the three broad things. So keeping that in mind, so if you have a patient whose abnormal topography may have been missed, or there may be something abnormal in the cornea, which could be screened for, they may obviously, if they are younger, if they have any allergy or pregnancy, will predispose that further for these patients more so. For the other group in which we do not know the risk factors, like in the first patient, there was the eye rubbing history, that may also just be the reason for it.
So whatever the reason is, you are sure that if you see a post-LASIK ectasia, there is no point in documenting its progression, straight away go ahead and cross-link it.
That is the tendency, yes. But having said that, there have been patients who have had post-LASIK ectasia and have come to us pretty late. And I've seen, so they had a risk factor of pregnancy in most of the cases, but they have been stable. So those are the question marks, the ones which we don't understand. But otherwise, yes, I think generally I still tend to go ahead and do cross-linking.
So what you want to say, since, as Himanshu also said, since incidence is low, so we are not very sure, but we can, are on the side of advising cross-linking in post-LASIK ectasia. Himanshu, in case you see these, we have seen two fantastic cases where they have done TGPRK as well, along with cross-linking. So what do you feel? What is your take on doing a TGPRK along with CXL in these post-LASIK ectasia patients?
So because interestingly, we have many options which help us to treat. Two parts of the treatment which are paramount. One is to stop the progression, And second is the visual rehabilitation. As like we had discussed last Kerakonnect, that we should have final destination in mind, but how you want to see finally this patient. So how to reach there, we have choice. So stopping the progression, there are factors like as the first case had eye rubbing. Now earlier, before Damien Gatinel was speaking about eye rubbing, I think we all used to laugh a lot about like how he over exaggerates eye rubbing, but we all now know that I think the direct and indirect, more so indirect eye rubbing is something which we miss out a lot. So making sure patients' sleeping posture is corrected and they're not pressing their eye with their arm or pillow and those things is very important. So that's one more factor which reduces the progression chances. Along with the other treatment option is cross-linking. So that's one part that has to be done. And then comes the visual rehabilitation part. Now we should have idea about how will we visually rehabilitate this patient. So if you think that you are going to take care with the glasses or contact lens, fine. But if you have enough cornea and if you think that you can reduce the ectasia and you can improve the quality of surface, then surely it's not a bad idea at all. And we should go ahead and do that.
Okay, Ashish, once you are doing cross-linking or TGPRK plus cross-linking, do you want to take any special precaution while you are, removing the epithelium? Do you want to use alcohol specifically because there's a flap down there? So, or any such experience where, because of the flap, you had some problem?
Yeah, true. So I think that's important that when you are doing these cases, one should be careful, because if you just do the full removal from the periphery, you may tend to dislodge the flap. Number one. Second would be that some of these cases we see later on are also at a risk for sort of a DLK because of the cross-linking process. So we tend to avoid alcohol in these cases totally. In fact, in most of our CXLs now, we tend to avoid alcohol. We basically use a mixture of paracaine and BKC and try and debride the epithelium with the help of just using these two things itself.
So you're saying that you would like to debride from center to periphery and ensure that, you would like to see where is the hinge so that you don't come from periphery to center, so that inadvertently you don't damage the flap, right?
Yeah,
So
correct.
yes, we can have different methods like Ashish follows that. I follow the alcohol part of it. I somehow, I don't know whether Dr. J.K. Reddy is here, but his viscohol is something which really works quite well. And I really am quite fond of that viscohol. Allows me to keep the alcohol for the adequate time. And then the removal is pretty easy. So in my hand, I do prefer alcohol, especially in these cases, as you said, I don't want my flap to dislodge. And also a minute to pay attention to the hinge site would be very important, and note down on paper so that when you are sort of removing, you may have an idea which side you want to sort of give strokes to and to remove the epithelium.
So you want an very easy removal of epithelium. So you don't want to, face resistance, and during that resistance, you may damage the flap. Rajat, you have good experience about TGPRK and CXL in these cases. So do you want to add anything on specifically regarding TGPRK?
Yeah. So first and foremost, I have used PTK method of removing epithelium. In these cases, I seldom use alcohol or visco. I use PTK method. I don't have a entire segment OCT to measure the epithelium, so I take a standard 45 microns and remove the epithelium, and whatever is left behind, I treat it with the second step. So in my case is actually incomplete. I did only a PTK and just a 20 microns ablation in the right eye because the thickness was 433 microns, and a deep ablation in the left eye. What I have specifically noted in post, I have done only 2 cases of post-lasik ectasia, TGPRK with CR, and I've done more than 50 in Keratoconus. In both the cases of TGPRK in post-lasik ectasia, what I have noted is epithelial hyperplasia over 2 to 6 months. I have a data to prove that if I'm allowed to show, I can show that. So that epithelium, once it's healed at 2 months post-op, and then you see the epithelium, the same cornea epithelium around 6 months post-op, there is hyperplasia of the epithelium. The thickness of the cornea increases. So this thing, actually, I noticed this while making this presentation. And then I went back and saw the epithelium thickness in the keratoconic patients in which I did a 8-inch protocol. and I found that the epithelium thickness is not increasing in the keratoconic cases. So this thing is something unique which I found today, that the epithelial hyperplasia is taking place in patients of TGPRK in patients of post-lasik ectasia. That probably
Okay.
the reason, I don't know.
So sure. So what I understand is that cross-linking you will do definitely. TGPRK in case for visual rehabilitation, as Himanshu was pointing out, if the patient doesn't have good vision with glasses, you think of something else, and then TGPRK may be considered. But you also said that the data again is very low, so we are not very sure, but this can definitely be one of the treatment modality. So to discuss more things, I think we'll see next case.
Can I just add a small thing there?
Yes, please, Rishi.
Yeah. So I think a good middle path is to use the Cretan protocol, in which you're just doing a PTK with the laser, and you're just shaving off a little bit of that tip of the cone, and doing a cross-linking after that, of course. So
Himanshu?
you're doing a laser-based PTK and shaving a little bit of the cone there.
So Himanshu, we know that in keratoconus, we don't have a smooth thickness of epithelium, right? So Rajat is saying that he removes just 45 microns all over. So, but we know that there is somewhere it may be 50, it may be 55. So for you, do you feel that you would like to remove it manually with viscohol or anything, or you feel that PTK is a decent method?
So I follow a little different thing. So post-lasik ectasia, my management would include, in fact, invariably intact. So let's keep aside post-lasik ectasia part. But when we talk about topo-guided PRK part, now I personally do one thing like what Rajat did. I remove the epithelium 50 micron without measuring that whether I am having 45 micron or whatever amount of epithelium. So by default, in the center part, I just make sure that it's not more than 50 micron. But the idea is that with PTK, when I remove the epithelium, my topography does not change much, because whatever topography guided treatment I'm doing it on a surface which is epithelium, which has a certain type of topography. And based on that, I have decided my treatment. Now, if I remove epithelium, and if epithelium thickness is irregular, the topography there on the Bowmans will be a little different. And this is not what I had planned for. So instead of that, what I do is I remove 50 micron from the larger zone. Hence, the topography still remains what I had planned for, and it may become more predictable. Now, again, I shouldn't say that that's the ideal way or something. This is what I logically think in my hand, and this is why I follow this PTK method for epithelial removal in keratoconus, not in post-lasik ectasia.
Okay, so if we summarize, for if you're post-lasik ectasia, cross-linking, you can definitely go at TGPRK if you have done enough and you have some confidence. You can think about that if the vision is not good with glasses. What are the other modality for rehab? So let's see that next case. Shabina, can you play the next case, please?
I am presenting a case of post-lasik ectasia managed with intracorneal ring segments and cross-linking. A 30-year-old female presented with diminution of vision in right eye. She gives history of undergoing LASIK in 2013 from elsewhere. Her uncorrected visual acuity in right eye was 624 and in left eye 69 parts. Right eye did not show any subjective acceptance. There was Caesar reflex on retinoscopy, and vision improved to 6.6 with mini-scleral contact lenses in right eye, and left eye improved to 6.6 with 0.75 diopter spherical correction. The tomography of left eye looked relatively normal, but the right eye tomography looked like this, where the thinnest Pecchi was 432 micron and Kmax was 51.1 diopter. However, 6.5 mm OZ showed pachymetry of around 550 micron. On curvature map, there is inferior steepening, inferior-superior asymmetry of 13.1 diopter and skewing of radial axis. Also, there is elevation on both anterior and posterior floats. The similar picture also shown on topography map. So the diagnosis of right eye post-lasik ectasia was confirmed, and patient was planned to undergo right eye intracorneal ring segments plus cross-linking, and left eye we plan to observe as of now. This was the parameters used for the intracorneal ring segment. A single 6.8 mm inner diopter and 7.8 mm outer diameter intact ring was implanted at 170 incision site It was of 350 micron thickness and a single ring or single segment was implanted in the inferior quadrant. The eye was subsequently taken up for cross-linking where mechanical debridement of epithelium was done in the 9 mm OZ. The area over intact ring was excluded from epithelium removal and it was further cross-linked with standard Dresden protocol. This was the slit lamp picture on post-op day 1 showing intact ring beautifully. 20 days post-operatively, the tomography map looked like this, showing a better regularized anterior corneal surface. And 3 months post-operatively, again the surface looks regularized and patient improved to 612 part with this correction. To give you the 3 months result, this was the picture of pre-op 1 month and 3 months. Patient is now followed up over more than 1 year. She is doing fine with glasses and also accepting contact lenses very well. Thank you so much for your patient listening.
Thank you, Yatri. So Himanshu, when do you say that, okay, now I'm going to take it for intracorneal ring segment? And how do you take a call? 1 segment, 2 segment? What are your plan of action?
So, because for me, unless proved otherwise, post-lasik ectasia, I'm going to do an index with cross-linking. Having said that, I would look at the ectasia, how bad the ectasia is. The reason behind that is that in post-lasik ectasia, the ectasia is very uniquely limited to the inferior part and limited to one area, whereas the other hemisphere of the cornea is actually pretty good and pretty flat, and it still remains that flat. It maintains that flatness. So in intacs, a single ring in the area of ectasia, if we put, that flattens down the cornea, and it actually makes the surface as if the post-LASIK eye was looking earlier. And when you combine it with cross-linking, the cross-linking uniformly further flattens the eye, and not just the area which is already flattened, further flattening. So I personally believe that if I have to put intacs only for one indication, it won't be keratoconus, that would be post-LASIK ectasia.
Superb. Ashish, so while you are placing an intact ring, so do you want to take into consider anything specific because there is a flap? So is it possible that you might go into the interface or any specific pearls you would like to share?
Yeah, frankly, because I do not have much of experience with intacs, I think I'll pass this question to Dr. Himanshu or anybody else in the panel.
So Himanshu or Rishi, if you are around, if you had any problem specifically because there is a flap.
So yesterday's case, when I was putting the ring, now what happens is so because the ring, I would, one thing about intacs is it underperforms rather than overperforms. So I prefer the SK ring, which is closer to the visual axis compared to the regular ring. So from this, rather than the ring which you were talking about, I would prefer a little closer. So SK ring would be the one which I would prefer. So I was holding the ring, and the forceps has the bigger slot for ring compared to, so it's for the regular ring size, and I was holding an SK ring with that. So it sort of moves, toggles inside. And when I was trying to put in the channel, I actually ended up going under the flap, and I started seeing that my ring was moving not towards the channel, it was going in some other direction. So I had to stop and make sure that I end up opening the channel and go in the same place. So you're absolutely right. Many times it may become difficult on table to judge that we are at proper plane. And the easier plane is your flap, under flap surface. So there can be chance to insert the ring there.
Yeah, so I had one patient, I remember when I was doing this, and inadvertently it went into the interface and I had to postpone that particular case. So Himanshu, suppose you are combining intacs, and you said that, we all now on the same page that post-LASIK ectasia, we are definitely going to cross-link. Intacs plus cross-linking, intacs followed by cross-linking, cross-linking followed by intacs. What is your take out of these three?
Okay, so I think there is not much scientific answer. We had done studies and unfortunately we couldn't prove much. Logically speaking, many times we come across arguments that once you do cross-linking, then in-text does not work. But this on the same page, when we started doing biomechanical strength experiments, or rather we were like clinical part of that, cross-linking and looking at how much the biomechanics changes, the change is so minuscule that I mean, it's just statistically significant and not usually clinically significant. So with a machine like ocular surface, I mean, any machine which gives you biomechanics, none of the machine actually can give you a significant, hugely amount of stiff cornea. It only happens in the Hydrops presentation where that big cornea becomes so stiff and something. No, but in actual real life, the corneas do not become so stiff. So if you do cross-link, then the effect of in-text does not come, or intracorneal ring does not come. That's not true. That's just a mind block. It does not happen like that. What I prefer normally is more for the purpose where I do on the same day in text, and which is followed by cross-linking. Having said that, if you span it differently, and if you do cross-linking first followed by in-text, it's absolutely fine. There's absolutely no harm in that. And similarly, we have had in-text first, and then we started doing cross-linking. So there were many cross-linkings which we did after in-text, and which was also fine, except we found initially that there were sterile infiltrates around the ring where we had removed the epithelium from the ring surface. So Vikas, I just want to highlight on this slide, if you can just go back to show the difference of 3 treatment protocol. Now, one is cross-linking. So you can do cross-linking in post-lasik ectasia. What it does is it possibly flattens the flat area also. So ocular surface or the corneal surface still remains irregular, and the flat surface will further become flat, and there would be relative steepening on the cornea. So visual rehabilitation part, this does not work as well. It has to be followed by then hard contact lens. Whereas in-text, if you see, as soon as you put the ring, the surface or corneal surface becomes pretty regular and looks like as if it's a tangential map of post-LASIK surface. And this actually keeps improving with the time. So that's the advantage of combining in-text with the cross-linking part. This is the topo-guided PRK and cross-linking part. Now, remember, topo-guided PRK would not understand how much to flatten the steep part and how much to steepen the flat part. So it's still going to change both of them, and it's still going to steepen the flat part, flatten the steep part. But the irregularity, when you have such huge amount of irregularity, superior inferior asymmetry, it's nearly impossible that you can take care of the entire thing. Now, having said that, can't we combine them together? Of course, we can combine them together. When you do in-text, and if you have a smaller area of irregularity, and if you are able to get a good topolizer, and if you are able to get a good topographic values, repeatable, and if you want to still go ahead and with a smaller optical zone treat, you surely can do that. There's no harm in that. But that itself would be good enough.
So again, I'll just summarize it. Post-LASIK ectasia, cross-linking for sure. If the vision is not improving with glasses, you have 2 options, in-text or TGPRK. Looks like that in-text maybe slightly better in these cases, but we can do TGPRK also. Rajat, you have a comment, so just 1 minute.
I want to ask Dr. Himanshu sir, is it worthwhile to say that if the irregularity is less, we could try a TGPRK in those cases? If the irregularity is more, we could go ahead and go with the in-text.
100%. I don't think, Rajat, there is anything right and wrong here. Yeah? Whatever works in your hand, if you know the outcome, what you expect from that, it's fine. So if you expect that, you know what, I have a huge amount of ectasia, but I'm just able to flatten the smaller area, that's absolutely fine. We should know what we expect from that particular thing. That's
in fact, we were trying to review literature, and there's not much literature on this to substantially prove or disprove anything. So Dr. Basak is around. Dr. Basak, do you want to make any comment on your TGPRK, cross-linking, in-text? anything on keratoconus, post-lasik ectasia? You need to unmute yourself. Also looks like that. Okay. Okay, fine. So Rishi, do you want to add any specific comment, quick comment?
So I haven't really tried too much of intacs in post-lasik ectasia, but I think I want to go back and do that. I've been essentially doing topographic guided PRKs, trans-epithelial PRKs with cross-linking and getting moderate results, just like Himanshu says.
Fine, great, fantastic. So for the last question is that, do you see any epithelial ingrowth, DLK, or mainly can there be a recurrence of post-lasik ectasia? So ectasia, you've done cross-linking or whatever. Do you feel it can recur also, Himanshu, Ashish?
So it's not that common to have progression again, but has it not been reported? Of course, it has been reported. In fact, I guess Demil Gatinal had one case report which he had published that they did cross-linking, and for probably a few years, the post-lasik ectasia had stopped, and then again it progressed. And of course, he was referring to the indirect eye rubbing part of it, and even other eye progress after like 5 years or something like that. So it can happen.
Great. So there's a question by Dr. JP Chug. He says that 32 years old female, post-lasik ectasia, vision is 6'9" with contact lenses, and there is an increase in astigmatism over 2 years, PACI around 400. So you have done this thing. So and he says that should we continue with the contact lenses for visual rehabilitation? Patient is comfortable with contact lenses. Ashish, do you want to take it?
I mean, she's not been cross-linked yet, is what I understand.
So I think the management, that's what he's asking, that of course, we'll do cross-linking, and if there is a contact, the patient is comfortable with contact lens, definitely she can continue wearing contact lens.
Absolutely,
right?
absolutely. That's perfect.
Okay.
So
great.
one last question, please. So if a lady who is pregnant comes to us with ectasia, so how much time after lactation or after pregnancy should we wait before we go ahead with the surgery?
So Rajat, we had covered this in the last webinar, and we had discussed that, although we don't have much of data, but just to be on the safer side, so that otherwise if something bad happens, patient might correlate with UV light, but the UV light that gets delivered, the quantity is very less. We have already covered it. In the best interest of time, I think we will shift over to the next part of our webinar, that is on PMCD.
One part, because I would just like to add one
please.
part here about the cross-linking part. Now, typically, if you intuitively see, when you want, in post-lasik ectasia, you want strength in the posterior stroma. So typically, entire literature is about doing a conventional cross-linking and using 3 milliwatt for 30 minutes, and the Dresden protocol, most of them follow. Having said that, there are cases where it has been reported, many of them where they have done accelerated cross-linking. Now, sometimes it becomes quite confusing to understand that if the anterior surface or the anterior flap surface, which is just getting cross-linked in these accelerated cross-linking, will it still work? But the interesting part is, yes, it still works. Even Dr. Reddy showed the case with the 9 milliwatt for 10 minutes. We all do accelerated one, and we have seen decent result. So we really don't have idea, though the literature out there, vertic is not out there. People still would, if you don't have doubt, you should go with the Dresden protocol. But there are people who have done different protocols.
So we generally do Dresden only, because I feel that there's enough literature to support is quite time and tested. In our hands, we have seen that it rarely fails. So, but you are right that one can do accelerated as well. So may I invite Sharon? Sharon, you are around? Sharon?
Yes. Hi.
Yeah. Please take it forward from here. Over to you.
Yeah, in the meanwhile, there's a question. What is the opinion of the panel on RK, post-RK ectasia?
So post-RK ectasia is, Sangeeta, it's very very biomechanically different from post-LASIK ectasia, post-laser refractive surgery ectasia, and cross-linking doesn't work there. If the ectasia is very significant, suturing them would be a better option rather than thinking that cross-linking would help it to close those wounds. Basically, it's the open wound which is the culprit there. So cross-linking doesn't work there. Suture, compression suture or encerclage suture kind of thing can work. In worst case, can think of lamellar keratoplasty also.
So we had, I think, 3 cases of post-ectasia over last 4 or 5 years. And we had, as you rightly said, and I had discussed with you also, Himanshu. So we had done compression sutures, all of them, but we did it because with contact lenses, vision was good and they were tolerating it well. So here, I think if patient cannot tolerate contact lenses or vision is not improving with contact lens, there is no point. Straight away go ahead with DLK. Otherwise, if you want to stabilize it, sutures works well, but we have to be careful because there are areas that is very thin. So, you need to be slightly careful while taking those sutures. Sharon, we will not hold you more.
Hi, everyone. Wonderful discussion till now. So we'll move on without further ado to our next section, which is on pellucid and marginal corneal degeneration. So the challenge with PMCD is that we know it's, even though it's part of a spectrum of ectatic disorders and we somehow seem to club it with keratoconus, there's a lot about it which is very different, right from the appearance to the structural changes to how it responds to treatment. So through our discussion today, we hope to bring out the differences and discuss what challenges we may face in managing PMCD. So the big, the challenges with PMCD start right from seeing, trying to diagnose it. And I think we'll start off the discussion with something which we have to deal with every day, which is the topography. So Dr. Radhika, what do you think are the key points to diagnose PMCD compared to keratoconus on topography?
Yeah, first of all, thank you so much, Dr. Vikas, Sharon, and Purvasha for this interesting selection of topics, and much obliged for having me over here. So to answer Sharon's question, basically what is PMD? PMD is a disease where there is a thin band of inferior cornea, which is present there for reasons not completely understood. And beyond that, there is normal cornea extending up to the limbus, but most of the pathology that we see is above it, where that thin band produces a flattening in the vertical meridian, and it also produces bulging just above it, which goes on and enlarging laterally. So that is what PMD manifests as. So if we extrapolate it to the tomography, so that is what is seen as the so-called classic crab claw appearance, which you have shown in the first picture in the quartet. And this also translates to a similar kind of pattern in the anterior elevation map, which you're seeing on the right-hand side. But we stop for a minute and think that, these don't really, shout out PMD, because any thinning which is produced in a similar part of the inferior cornea could also produce these kind of effects. So what other thinning do we have which is there in the inferior cornea? It could be an inferior keratoconus as well. We know that for the same size of cone, keratoconus is a wonderful mimic. When it is present in different parts of the cornea, it produces different kind of pictures, even though its quantum is the same. So the map that would probably give us the diagnosis to some extent would be the third one of the quartet, which is the pachymetry map. Why? Because for the simple reason, even before tomography came into existence, we all knew, even as postgraduates, that the one difference between keratoconus and PMD is that the thinnest part of keratoconus more or less correlates with the steepest part, whereas in PMD, the bulge does not correlate with the thinning. So if we look at the pachymetry map, the PMD would probably show us a lot of thin points in the inferior periphery. And those kind of, sum up into a triangle, and they kind of start encroaching towards the center, where they become narrower and narrower, and then the cornea starts becoming normal in thickness, which I'm not seeing very much in the map that you have shown. That's also probably because we are not looking where we have to look. So your map over here is the classic, 8mm short map that we normally see in a rush when we screen the LASIK patients. And this map may completely miss out those areas of thinning which we see in PMD inferiorly. So for the same reason, bad screening also quite often misses out, picking up PMD. Even the pachymetry progression, you can have very flat progression in PMD because you need to look where you have to look, which is the inferior part of the cornea. So what I'm trying to say is that you can have crab claw appearance, or you can have, the kissing bird appearance in both keratoconus as well as PMD, depends on the location. But if you did see these pachymetric points which are thinner, which are clustered in the inferior part, then probably you're dealing with PMD, whereas in keratoconus, you won't find those. You're looking at something which is like PMD, but is actually a keratoconus. The one other giveaway could also be the corneal asphericity, because we know that you get a hyperprolate cornea unquestionably in keratoconus. Even in a form frustrated keratoconus, the prolateness is more, but it would definitely be a little less prolate or even oblate when you look at the Q values in a PMD patient. So you need to distinguish between the two. Why? Because both the timing as well as the method of cross-linking is probably different between the two diseases, which I'm sure you will tell us as you take us along.
I think that was very lucidly put, and that's exactly the reason I showed this 8 map, and we were going to discuss about the large diameter. This is where the confusion starts about whether it's actually just a decentered keratoconus or a PMD. And as you very beautifully showed, that we have to look at the Pachy map, and that's where the role of large diameter maps comes into it. So going forward, now that, okay, we think that we have a PMD, how is PMD progression different compared to keratoconus? Dr. Rishi, if you could just elaborate on this point, because it's so important when we are trying to manage these cases.
Hi, everyone, and thanks again for having me here. Yes, so you're talking about how PMD progression is different from keratoconus, right?
Yes.
So we know that keratoconus, PMD typically presents a little later compared to keratoconus, and it also continues to progress beyond the traditional third decade, like we see keratoconus usually arrests in the late 30s. PMD doesn't really stop there. It can continue to progress beyond that. The only good thing about PMD progression is it's very, very slow. So you may see a very, very slow progression over time, and it's really very difficult to say when it has stopped progressing. That's why even effect of cross-linking, if you want to assess in PMD, sometimes you have to wait a long time to really see if it has worked, or it's just, it's just progressing very slowly, or it's just natural arrest of the disease. So progression tracking in PMD is a challenge. Again, like Dr. Radhika mentioned, most of what is happening happens in the extreme periphery of the cornea. So imaging that becomes a challenge unless you have really good quality equipment, which many of us don't have access to. We have basic topographers which only image the central cornea. So because of those reasons, tracking progression also becomes a problem. So yeah, it is different. It continues to progress beyond the third decade as well.
Exactly. So that's a very important point which you raised, because when in a keratoconus, if we see a patient who's 35 or 40, we are less concerned, and we probably, keep them on a slower or longer observation, more spaced out. But in a PMD, it may not be so for various reasons. Which brings us to a point which you raised about measuring these PMD itself. So do you think that then our topographies may not be as repeatable there? And we had already touched on how the large diameter maps works. Dr. Radhika, anything you'd like to add on this?
So yeah, the same thing that Rishi said, that if there is a doubt, I would place a lot of reliance on the against the rule astigmatism that I see. So a lot of the diagnosis of PMD is bordered on suspicion, basically. You see an older patient, you see a funny kind of astigmatism. You don't see any features of keratoconus on the slit lamp. You will not get scissors. You will not have, striae or scarring most of the time. You get an against the rule, astigmatism. So, and the patient is a little older. And on slit lamp, if you're lucky and if you're very astute, you'll pick up the inferior thinning. Otherwise, these are the patients that you should insist on looking at the 12 millimeter diameter. And as far as progression is concerned, we really don't know, because even when it is progressing, it may look a little static. So it is, I think, anybody's.
Yes. So again, to add to the confusion that we already have, there are certain entities like this one, where they described something called pellucid-like keratoconus, where you can see in the maps, and this is from an article which was published quite some time back, where the steepening is central, but the thinning seems to be peripheral. So unlike this, and the other eye has something which looks like a keratoconus. So Dr. Rishi, do you have any experience with this? I think it's fairly rare. What would your views be on this?
It's actually not very rare. I've seen a lot of these.
Exactly.
The map looks exactly like pellucid, but you don't have the inferior thinning. Essentially, I think that's the key point to differentiate between a PLK and a actual pellucid, is that inferior thinning. If it's visible on the slit lamp, it's great. But if it isn't, then it's the large diameter pachymetry map, which will really...
Which will be the clincher.
Yes. So they have described the bell sign, which is the bell sign.
Yes.
It's essentially that only, that your pachymetry is progressively thinning from top to bottom in the shape of a bell. That's what it is.
So basically, like we already knew that the thinnest point is very peripheral in a PMD and is very far off from the area of the maximal bulge, is something that we knew all the time. But Sinjab's article kind of brought it out and made it, very lucid, that you could have a crab claw if you had an inferior cone, but you need to see this peripheral thinning to be able to make a diagnosis of PMD.
Nice. So we move on to the management options that we have. And the first one, of course, like in many of the ectatic disorders, is collagen cross-linking. So there have been a lot of articles, but many of them are smaller and a few larger based. They do say that, some of them do say that collagen cross-linking is a fairly safe tool, and it does help stop the progression. But unfortunately, there are incidences where we see a progression even after a PMD. One reason for this, which has been described, is that the type of beam. So because the area of interest is quite peripheral, then the beam profile may not be as uniform for that peripheral area as we expect. And that has been told to be one of the reasons. So we'll start with this very interesting case, which has been submitted by Dr. Vipha.
Can you increase the volume, Sharon?
Okay.
You will have to
replay it. We couldn't hear a thing.
One second. It's on the maximum of the video.
No, stop sharing.
Okay.
Before you click share, after you click share screen, there's a share sound option.
Just give me 1 minute. Okay, I've done the share sound option.
You can go in PPT mode, full.
Start again.
Yeah.
Sharon, your slides aren't moving.
Maybe Shabina, if you have that video with you.
Yeah, we will share.
Yeah, please share the video.
Sharon, you can stop sharing.
Yeah, please share the video of Dr. Vibha.
In the meantime, there's a question. Shall we take that?
Yes.
There's
Okay,
a question.
start.
Okay, yeah, go ahead.
Good evening, everyone. Today I am presenting a case of progressive PMCD. So this 44 years old male presented to us in May 2018 with complaints of TOV in left eye more than right eye for 15 days. The best corrected vision in right eye was 6.6 and in left eye it was 6.18 with no further improvement with contact lens. Rest of the anterior segment was within normal limits. This was the pentacam of right eye with a Kmax of 49 diopters. This was the pentacam of left eye with a Kmax of 79. So the diagnosis of PMCD was made and plan was to cross-link both the eyes. As the right eye was the better eye, CXL was first done in the right eye. But for the left eye, the patient was lost to follow-up for the next 5 months. And then he presented after 5 months with this situation, and the pentacam showed the Kmax of 88. So it had clearly progressed, and vision has also reduced from 618 to 6 by 120. So it was planned for DALC. But the patient was lost to follow-up for the next 2.5 years, and then suddenly he presented with pain, watering, and DOV in the left eye, as that was due to the Hydrops, for which desmetopexy was done. After 1 month, the edema was resolved with the best corrected vision of 6 by 360 and correcting to 624 with contact lenses. At this visit, the right eye also showed slight progression even after CXL, but no intervention was done, and we kept for observation. But the patient then reported after 8 months with complaints of DOV and strain in the right eye. This was the pentacam with the thinnest Pachy of 406 and Kmax of 75, which had clearly progressed, and it was planned for DALC. But the patient is still lost to follow-up, and he has not got operated. So this slide shows the progression of the PMCD in the right eye, which was already cross-linked. So the question is, how common is the progression in PMCD even after CXL? Thank you.
Right. So that's exactly the question which we need to discuss is compared to keratoconus or even otherwise. How effective is our cross-linking in these conditions? Dr. Radhika, would you like to discuss this?
Yeah. So again, the principle of cross-linking in PMD is probably slightly different from. I think we are replaying that. Yeah. Different from that in keratoconus on many counts, because we need to know what we are targeting. Are we targeting the thin band and making it kind of stronger, or are we targeting the rest of the cornea and stiffening it, and are we preventing it from sagging in front? So it's common sense that we should probably be doing a bit of both. And even before the question of whether the CXL was effective or not, I even have the basic question as to whether we have a pachymetric cutoff in the thin area when we do the cross-linking at all, like we have in keratoconus. Probably not, because I would think that if you had thin cornea and you did cross-linking without any kind of tailored protocol, then you'll probably hurt the endothelium or cataract or something like that. But over here, since the cornea is peripheral and the central cornea has adequate thickness, I don't think there needs to be a pachymetric cutoff in the thin area before we do the cross-linking. And the cross-linking essentially needs to cover a bit of both the band, which is responsible, as well as the cornea that is sagging above. So a little bit of decentration of the epithelial debridement, along with a little decentration of the beam or a larger beam of, say, 9 millimeter or something is what we employ. All the time also, taking care that you protect the inferior limbus. So if you strengthen the band and if you strengthen the cornea a little above that and you fortify the limbus, then possibly you may prevent progression of the PMD.
Yeah, I think that's very valid points. Dr. Rishi, anything to add regarding how we do the cross-linking in these cases?
Yeah, before this, I'd just like to ask Vikas, this case that progressed, did you use I'm sure you used one of the older machines which had a Gaussian beam of the cross-linking, right? So what happens when you do pellucid is the inferior part will have probably a weaker cross-linking because it's the peripheral part of the beam. So what I like to do is actually decenter significantly and try and keep the central part of the beam closer to the thin area, because essentially that is the area which needs to be treated rather than the cornea.
In that case, how do you protect the limbus?
You have to protect the limbus. So I put tiny bits of XL sponges, the limbal tissue, and that's what works for me.
But I also feel there's no proof for this, that it is definitely important to fortify the thin area, Rishi. But I also feel it is equally important to stiffen the sagging cornea.
Both.
I think that's also a reasonable thought. This is what I'd been thinking.
Nothing to prove or disprove.
Yes. I possibly think that probably a better approach would be to stiffen the inferior cornea first, and maybe a while later one could consider a topography guided treatment for the central cornea along with an accelerated cross-linking. That might be probably a better approach, maybe 6 months or 1 year after the initial cross-linking.
And Sharon, we don't have much in the literature for this, no?
No, we don't have much literature. So
in fact, most of
there is
also is very short follow-up. So, you know, progression,
yes, very short one.
That it's not progressed, but it's too short to say it's not progressed.
Exactly. Yeah. Plus, there are smaller groups, numbers in compared to the Keratoconus paper. So the amount of literature we have is very limited.
And Rishi, Vikas or Sharon, do you have any pachymetric cutoff for the thinnest part of the PMD before you would decide you won't do cross-linking for this PMD?
So I do have a cutoff like in Keratoconus, but the threshold is a lot lower. So okay. I will not worry about the 350 micron, for example.
Yes. If those the ones which, if it is very steep and very thin, you know, then we know that these patients, they don't, you know, fit well with the contact
benefit much from the cross-linking.
So more that DLK. Yeah.
I have one question, just a curious question, that what are we trying to treat with cross-linking there? I mean, in keratoconus, we possibly are preventing the slippage of collagen fibers. Here, uniquely, paralimbal region, one band, which across just goes circumferential. And I don't know what happens and what are we treating there by doing cross-linking? So how it's going to help? I'm just curious. I don't know.
Very good question, Himanshu. Even I've thought this. Nobody knows. But the fact is, a lot of my patients, at least I feel, have benefited from cross-linking, even though I was very skeptical.
So we all do that. We all do that, but we don't know what exactly we are treating.
You're right about that.
Exactly.
So that will be a good research question.
But whatever was at play was working most of the time.
So if we extrapolate what we understand of keratoconus, which is probably not the best idea, but even then, you know, trying to regularize the cornea, then maybe topo-guided PRKs may work. And this was a 33-year-old gentleman who had a progressive PMD and underwent a topo-guided PRK with cross-linking. This is 3 years of follow-up. So even though he's very stable, his vision and refraction may not have changed as much as we would expect or hope. So which brings us to this question as to what is the role of topo-guided treatments in this case, and how do you choose a case or measure outcomes? Dr. Radhika?
I've not done many of these, probably, you know, one odd patient, that's all. But the way I probably would approach this is that if the patient had reasonably regular cornea or less of a protrusion, but the thinning worries you, then I would probably go only for cross-linking. But if along with the cross-linking, you want to regularize the cornea, there is a bit of irregularity of the cornea, your aim is to, you know, improve the surface to give, you know, better both corrected as well as uncorrected vision, or make it more suitable for a contact lens fit, then probably you would want to do a PGP-RK. But the thing is, I don't think, you know, refractive correction is an aim at all. We are just trying to regularize the surface. And we must also understand that topography of these patients will have a lot of outliers. So we need to select the maps which are most consistent. And, you know, we probably do a, you know, 50 micron ablation or something like that.
Dr. Rishi, anything to add, or Dr. Himanshu, on how to plan this?
Pellucid is, there are two types of patients. There's one type of patients who have very good best corrected vision because their cylinder is not very large. And with spectacles, they come to 6x6 and they're pretty happy with their corrected vision actually. So if they're happy with their corrected vision, I think just doing a cross-linking is reasonable. And the moment your vision, and then you have that subset which has really bad vision because the disease is actually quite advanced. And in those cases, I think even just doing a cross-linking may not be enough. My threshold to doing a lamellar procedure or a wedge resection is lower for these patients, because whatever you do, you will not get a very good outcome even if you combine it with a topography guided, because there's a limit to how much cylinder you can treat on that.
So because it's so peripheral,
you can just reduce it, but you can't give them great vision anyway. So then I would rather go with either a wedge resection or a lamellar keratoplasty or something of that sort.
So is the ones which come in between the two categories that you said that probably benefit with the
probably benefit, yes, the mild
so
to.
I basically don't do topography guided treatments in pellucid. I just do cross-linking if at all, and otherwise I will
contact
do
lens fit.
something else. Yeah, and of course contact lenses and all are always there.
Yes. So taking this thought further, and part of the discussion which we were having of how maybe we should do something to try and support that ectatic region, to regularize the ectatic region, we then have our next modality of treatment, which is Intex. And there have been certain studies, and we've also done Intex for to correct pellucid, and they have shown fairly good results. But there are a few questions which are always at the front of our mind. Is that how do we adjust the ring such that to avoid the thin area and that make sure it's in the ectatic zone, how to plan. So if Dr. Radhika, Dr. Rishi, Dr. Himanshu, anyone would like to take and just tell us briefly on how to plan an Intex.
I've not done any, but I'll just say my thought why I've not done any is because I strongly believe that your zone where you're going to put the ring cannot be beyond the area which is pathological, which is peripheral.
Yes.
So you are only just regularizing the shape a little bit, but your pathology, which is peripheral to that, might still progress significantly unless you're sure that it stopped progressing. So, and if there is a possibility that the ring goes into the thin area, then you might have an extrusion. So I personally don't find it a very good idea to put this modality in a pellucid, but I don't have any experience. Maybe Himanshu or others who have done it can talk.
Dr. Himanshu, any other views on this?
So if you look at the shape of PMD, it's very intuitive that if you put a asymmetric ring or single ring there, it should work. Interestingly, well, it may work, but as Rishi was saying, we have to look at how long it's going to work. Right? I mean, if we do surgery for possibly for a small period of time, that okay, for 1 year it may help, or 6 months, that's a different thing. But I don't think we treat patients like that. We treat patients for the longevity of the treatment. So if we are not treating the root cause, which is much periphery, there are these cases where they thin out, then the ring extrude. There are hydrops after such kind of thing, and it somehow does not then later on help you a lot. But if or cross-linking, we were so sure that we can beat the chest like Keratoconus, then sure, I would say probably yes, we can go. But unfortunately, we are not able to stop the progression. So in that case, that won't be my priority for sure.
We'll move on to the next options which we have, which are partly the various corneal transplant based. And this case and video is Dr. Rishi Swarups, and he will be running us through the wedge resection video. Dr. Rishi, if you could just say what's been happening in the case.
Yeah, so this is something I do in all ectasias. I press the cornea with the Sinski hook, and depending on the amount of dimpling, I can make out which is the pathological area. Of course, I look at the maps also, but I correlate it clinically on the microscope. And it's very, very, very obvious actually once you start doing it. The amount of dimpling, the moment you come into the pathological area is much more. So I always mark out that area and see how it correlates with the maps. And basically that's what I'm doing. I've marked it out and then just kind of creating a little groove there. And you can either use a crescent blade or a scissor and just snip this. It's not necessary to go down to the Desmes level or anything like that. It's okay to kind of bunch up the tissue on it itself. It's all peripheral, it doesn't matter. So I'm creating a little pocket there because I want to kind of do something like a tuck-in using a lamellar dissector. I'm just dissecting this off. So although the topographic map might sometimes look wider, sometimes the area of pathology is much smaller. And that's what I felt in this case. And when you take compression sutures, your effect is actually beyond the area where you're compressing also. So in this case, I've basically done a lamellar dissection underneath that area and essentially trimming this out. You could move it faster if you want. Yeah. Yes, and then basically just suture it. You could use Tenzilo Merceline, or in this case, I'm using nylon, I think.
And these shows the excellent outcome pre and post. So with wedge dissection, definitely when chosen well, and we'll discuss that a bit. If we could play Dr. Pratik Gujar's video, please, which is a large diameter dab.
This video demonstrates the technique of doing a large diameter DALK in advanced pellucid marginal corneal degeneration in a 60-year-old female. We start by marking with a 10.5 mm or 11 mm trephine displaced inferiorly to totally cover the thinned out cornea. A central 7.5 mm marking is also done. Pachymetry readings are taken, and trephination in the central 7.5 mm is done using vacuum trephine. We then debulk the anterior stromal layer using crescent knife, and then we try to achieve a central big bubble in the central 7.5 mm zone. Once a big bubble has been achieved, we deflate the big bubble and remove the posterior stromal fibers. With this, we have a central 7.5 mm zone, in which we have a Bayer DM. Now in the peripheral zone, we try to do a manual layer by layer dissection using 1/2 scissor and crescent knife, reaching up to the 10.5 mm trephine mark.
I think the video volume is too low. Can it be raised?
It's audible. It's okay.
Okay.
Once we have achieved this, we prepare our graft on artificial anterior chamber. The graft is approximately 350 microns thickness, and we suture it with 10 nylon sutures. This is the power difference map and 1-year follow-up of the same patient. Thank you.
I think that was an excellent demonstration of two very different techniques. So could we, while I'm just sharing the screen again, could we have a discussion on when we would decide to use either of these techniques? Where, Dr. Radhika, what do you think would be our judgment there?
Yeah, so basically it also depends on which primarily we are trying to address. Are we trying to build up the tensile strength of the thin area of the PMD, or are we looking at the astigmatism and the curvature improvement? Rishi's video looked very nice, and the result looks very promising. But the thing is, there are two angles to it. One is literature has shown that quite a lot of these wedge dissection and compression suture over a period of years slowly, steadily migrate back into the same, irregular astigmatism path. Okay. And secondly, with the advent of very nice skull contact lenses, very sophisticated fitment these days, for the curvature part of it, for the irregular astigmatism part of it, I would definitely recommend skull contact lenses, rather than compression sutures with prior wedge dissection. But on the other hand, if we find that the area is very thin, and like Vikas said, cross-linking is not going to, give much support to that area, and you're worried that it may hydrops at any point of time, I would rather do a, crescentic lamellar keratoplasty, which I have done a few, to give support. The only problem with the crescentic LK is that it does give the support, but then if you suture it all around, you induce more astigmatism. So, in that context, what Pratik did may be better because you're kind of evening out the, tension of the cornea by doing a large diameter TALC. But the one surgery that I've done in some cases of PMD has always been, crescentic lamellar keratoplasty. By taking advantage of fibrin glue, you may minimize the sutures so that you strengthen the cornea in that area without putting too many sutures to kind of tent up the astigmatism. So the answer to your question would be for irregular astigmatism, I would definitely rely on close contact lenses, and for strengthening the cornea, a crescentic LK.
Very nice. Anything to add, Dr. Rishi or Dr. Himanshu?
I think.
Rishi, what was your follow-up on this patient over a period of time? Did you find any recurrence of the astigmatism?
No, actually, she went into the opposite axis, and I had to then do some suture removal to correct it. She's doing well, but I also don't have too much experience with wedge resections. I think they are good for a temporary time. Maybe a few years, you can buy them some good vision. And if the disease stabilizes well and good, if it doesn't, you can always do a DALC later. So the advantage is because this is not a full thickness procedure, you can always do a DALC at any time.
But and no tissue is required also.
I did both eyes. She's doing very well, actually. She's extremely happy, and I've done.
So do you want to do a cross-linking now since she is very happy?
So I'm actually considering that at some point I will do a cross-linking. I've already done a cross-linking for her before, but because she was not
after wedge resection. So you have done and then freeze it over there, maybe.
Now that it's more regular.
Maybe I will do a topographic guided PRK with cross-linking at a later stage for this patient. All the older literature is from days when we were not doing all these things. Maybe this may be a reasonable thing to do as well. As long as it's a procedure.
Anything to add?
So I do wedge resection a little differently. So I use two asymmetric trephines.
Yeah.
One little smaller arc length trefine, say somewhere around 10.5, 11 millimeter at the limbus. And near the inner edge of the PMD, I take a larger diameter trefine so that you get a crescent, mark it with that, and use a fixed depth knife or diamond knife to carve out that tissue and then take suture. But what Rishi showed was that you don't need such kind of big dissection, and even smaller area can be done. So I never tried the way Rishi had done. Always done the other way, and this was more so when earlier scleral lenses were not available, and they were not as much affordable. Though most of the cases of PMD, the RGPs sit on the lower lid, and that's why they are fine. But if in cases those were where RGP was not sitting, in those cases I had tried mixed result. Can't boast anything much about it. About Pratik's video, well, I prefer to do a sort of decenter large diameter DALC and maybe tuck in part in the hemi part of tuck in so that I fortify the inferior limbal. But what he showed was more of a central DALC and larger and very nicely done. But
one point I would add to Pratik's video is it's important to make a paracentesis and let out some of the aqueous before you do the suturing, because these, especially the ones which are very ectatic, sometimes if you don't decompress the anterior chamber, it doesn't oppose properly. Yeah. So it's important to make the let out more aqueous and then do the suturing.
Very interesting discussion.
Sharon, I want a quick clarification over here. So all the red that we saw on the topography in Pratik's video is most of it is normal cornea, right? So the normal cornea is bulging more, but it's still normal cornea. So barring for the fact that sutures can induce astigmatism, why have we let go of crescentic LKs and why are we moving on to only DALC? Because I still feel there is a role for doing crescentic lamellar keratoplasty, which spares the pupil, which spares taking so many sutures. And if we use a stencil technique where we can, mark out the area and use some transparent material to mark out the same area in the graph and do a partial thickness lamellar keratoplasty over there, we may still be getting, reasonably good results. I have got them in a few cases, not too many, in the past.
I've done few of them, especially different techniques, and many of banana graph, especially making stencil. Works very nice, and it kept showing videos everywhere, and in conferences it's very nice, and you really feel very nice about it, but the visual outcome part of it is not as exhilarating. So same patient, other eye, when I had done a large diameter dark, large diameter dark are somehow very good in terms of the central irregularity part, where they make the surface much better. So patients do appreciate that part much more. So after doing a crescentic graft, if we are putting a contact lens on top of scleral lens on top of it, I'm not sure how much we achieved from there, but it's certainly a technique, and it can work in some of these cases.
Yeah, I quite agree with you, because if you encroach the pupil or you take so many sutures, then you are not leaving the surface very regular.
But also, I would differ on the glue part of it. Glue does not give strength there, and somehow these cases, if we are not able to suture them properly, they start gaping there. So
not only glue, a mixture of glue and sutures. Yeah. Which brings me to the point that you said, do all of your large diameter darks done in this context really relieve the patient of contact lens use?
Yes, most of them, I would say, unless proved otherwise, yes.
Actually, dial gives such beautiful outcomes that all these are more theoretical discussions.
No, even so especially Rishi, not even just regular dark, the large diameter
dark.
Because the central cornea has such little effect of sutures also. You get beautiful results.
Okay, so we'll move on to an interesting case which was submitted by Dr. Indrajit Kaur. If you could have the video, please. So this is a very different case, which was sort of a masquerade. So I will let her play.
Good evening, everyone. Today I'll be presenting an interesting case titled Magic of Tear Film. A 32-year-old male presented to us with complaints of blurring of vision in both eyes since 10 years, complaints of redness and watering in both eyes, which has recently increased, history of using contact lenses since 3 years. The interesting part of history is that he uses these contact lenses continuously day and night for 3 months and then changes them every 3 monthly. On examination, his unaided visual acuity was 6/180 in both eyes, with his own contact lenses 618 in the right eye and 636 in the left eye. Refraction is as shown. Slit lamp picture shows a congested eye with these angry-looking vessels encroaching inferior cornea and a localized cellular edema. Right eye shows the same. So a diagnosis of contact lens associated red eye was made. Patient was asked to stop use of contact lenses. Antibiotic and lubricating drops were given. 2 weeks later, when the cornea was allowed to breathe, these angry-looking vessels have just vanished away and the eye is white. But the best corrected visual acuity was still 6/24. So a pentacam was advised, which showed inferior steepening with a typical crab claw appearance in both eyes. So a diagnosis of pellucid marginal corneal degeneration was made. The mini-scleral lens trial showed 6/9 improvement, so they were dispensed. The patient was educated thoroughly about the do's and don'ts of contact lens. So my points for discussion to the panelists are: the vascularization seen, why is it only inferiorly and not 360 degrees? Which contact lenses are ideal for PMCD? And the importance of counseling in such cases cannot be underestimated. Thank you.
I found this an extremely interesting case because it highlights 2 points. It shows, of course, what can happen if you overuse the contact lens, but it also shows how beautifully a contact lens can correct these patients' vision and how comfortable it can be even in such an irregular cornea that they overuse these lenses so much. So I think in the interest of time, we will move to our next section, which is on acute hydrops, and it will be led by Dr. Purvasha. Thank you very much to all our panelists for this interactive discussion for this session.
Thanks is due to you, Sharon, and to Dr. Vikas for organizing this.
So we are not done yet.
No, definitely not. I thanked for this part of the session. I can keep thanking again and again.
So, good evening, everyone. And at the outset, I would like to thank Dr. Vikas and Cornea Society of India for this honor and privilege to be present with you all today. And now is the section on Hydrops. So, if we could have the first set of videos.
A very good evening to one and all. My patient, she is a 13-year-old girl. History was narrated by her mother, and she tells that a patient was suffering from redness, watering, and some white opacity in left eye since last 5 to 6 days. She tells that her daughter had an episode of seizures at the age of 6 months of her age, and followed by which she had developmental delay. She also notices and says that since then only she had squinting in both the eyes. Otherwise, she was systemically normal. On ocular examination, right eye had a visual acuity of 6/9 with an ectatic cornea. The vision was not improving above 6/9. And in left eye, she showed only presence of perception of light and projection of rays. And you can see that she had a lid edema with mild congestion, and the ectatic cornea shows an almost 8/8 mm of corneal epithelial edema, microcystic epithelial edema, along with stromal edema and a Desmond's tear. Treatment, we have diagnosed her as an acute hydrops, which was clinically evident, and we started her on steroid antibiotic combination 4 times a day, along with mydriatic 2 times a day, anti-glaucoma medications in the form of timolol maleate 2 times a day. Along with that, we have started her on eye drop NaCl and ointment at bedtime. She recovered very well, and this all happened in the pre-COVID area. After that, only on telephonic conversation, we could manage the patient. But we can see a very good scarring in left eye. But in right eye, she had a progression. And so we have asked her that she should undergo collagen cross-linkage to save the eye. And she agreed. We have done this collagen cross-linkage 3 months back, and patient is yet to come for follow-up. Thank you so much, and the case is open for discussion. Thank you.
Purvasha, you need to unmute yourself.
Yeah. The next video is by Dr. Geeta Behra.
I would like to thank CSI for the opportunity to present our case. A 16-year-old girl presented with sudden onset watering and diminution of vision in her right eye for the last 3 days. She gave a history of progressive vision loss in that eye for nearly 6 months. The BCVA was 1/60 in the right eye and 6/6 in the left eye. Her right eye cornea showed central elevation with edema and bullae with paracentral thinning suggestive of keratoconus with hydrops. The left eye appeared normal. The anterior segment OCT showed a Descemet's membrane tear and corneal edema. The topography of the right eye was highly abnormal. However, the left eye was equivocal. The curvature map showed an asymmetric bow tie pattern. The thinnest local was 503 microns, displaced 0.96 millimeters horizontally and 0.82 millimeters vertically. The Kmax was 47.4 D, was displaced 1.23 mm vertically. The back display of the left eye showed abnormal DP and borderline DF and DA and highly abnormal final D. The percentage thickness increase was on the lower border of normal. The pachymetry progression index was abnormal and the art max was borderline. The IHA index of height asymmetry was borderline and index of height decentration was abnormal. We proceeded with intracameral gas injection, 14% C3F8, and the patient is currently following up with us. So we have a few questions here. How common is this scenario with one eye presenting with hydrops and the other eye almost normal or possible form fruste? Is there any indication for doing left eye corneal cross-linking? If not, how frequently do we follow up the left eye for possible progression given the right eye history, or could it be something else? Thank you.
Hello everyone. I would like to take you all through a series of two cases and application of our learning in management of hydrops. 11-year-old boy presented to us with acute hydrops in the left eye. We planned desmetopexy. He underwent desmetopexy. However, to our surprise, his edema kept on worsening. At this point in time, we went ahead and did a penetrating keratoplasty, which had a beautiful outcome, but it got us thinking, could this be prevented? Could we have done anything differently? Was there a missing link? Could compression sutures have helped? We did some literature search and came across a few articles mentioning efficacy of compression sutures in hydrops. By this time, we had one more patient with similar presentation. We planned compression sutures. Let me take you all through his intraoperative course. Partial thickness compression sutures were taken perpendicular to the DMTR. To our surprise, we found fluid egressing from suture track right on table from few inferior sutures, as we can see here. Partial thickness sutures help by bringing together the torn edges of DM and thus reducing the gap and allowing easier migration of endothelial cells. Some sutures became loose right on table, which were revised. A bandage contact lens was placed at the end of surgery. So this is at the start of surgery, and this is at the end of surgery, where we can see a significant reduction in edema intraoperatively. On post-op day 4, his edema had resolved significantly with a PACI of 547 microns and a DM which was completely attached. He gained good vision with contact lens trial. So this was first case where we had to resort to PK. Well, this is the second one which resolved with partial thickness compression sutures alone without desmetopexy. I thank you all for your patient listening.
Thank you. So after the medical management and desmetopexy and compression sutures, now comes the video with the entire spectrum again.
Good evening, everyone. Today, I'll be presenting an interesting case of peripheral corneal hydrops. A 23-year-old male with history of eye rubbing, he presented to us and he was diagnosed with keratoconus. He underwent collagen cross-linking, and that was the year when the accelerated protocol was introduced, and hence the same protocol was followed. His keratoconus remained stable for almost 4 years, and later the patient was lost to follow. When he came in 2019, he had an irregular cornea where the central cornea showed a flattening effect because of the previous cross-linking. The peripheral cornea showed anecdotic changes suggestive of pellucid marginal corneal degeneration. Hence, a repeat cross-linking was advised. However, the patient did not agree and he was lost to follow-up. And he came to us again after 1 year, and the subsequent year scan showed a significant progression and a tuck-in DALK was advised. Patient did not agree for surgery again, and again he was lost to follow-up. After 9 months, he came to us in an emergency with peripheral corneal hydrops, and he underwent intracameral C3F8 gas injection along with compression suture. Even after 1 month of procedure, the corneal edema reduced little bit. However, it was persistent. So we did an OCT, and OCT showed a fibrous traction band. So after 5 months, we decided to remove this fibrous traction band. So he underwent Desmet stripping. After 3 weeks of this procedure, OCT showed a significant reduction in corneal edema, and the patient is yet to follow. This case is unique and interesting in that the keratoconus remained stable after cross-linking, whereas the peripheral ectasia remained progressive and ultimately resulted in peripheral corneal hydrops. And most of the literature studies have shown that wherever this type of hydrops was associated with fibrous traction band had neither responded to conservative line nor to compression suture with intracameral C3F8, and finally ended up with penetrating keratoplasty. Thank you.
Thank you so much for these cases. As we know that acute hydrops is actually a self-limiting condition which resolves within 2 to 4 months, and it's basically a non-inflammatory presence which has been seen, but there is significant ocular morbidity given that it is present in younger age groups. So basically, we would like to find out how to hasten this resolution. So I'd like to invite comments from Dr. Sunita ma'am, if she's around. Ma'am, we have seen that in the first case, there's medical management used along with hypertonic saline, steroids, and cycloplegics, lubricants, bandage contact lenses. So what is the rationale behind medical management in such cases? Is it really effective?
Yeah, thank you, Purvasha. So I think very nice videos and all spectrum of cases. Factor is the degree of involvement. Like, let's say if you see a case where you have more of a central involvement, central 6-7 millimeters, those kind of cases we can simply observe with medical management because they don't take much of time to resolve. So intervention is not necessarily required for those ones which are in the center, because resolution is far quicker. Having said that, we should still monitor those cases, because particularly in children, because when you have edema, when you have hydrops, many of the children can keep on rubbing their eyes even then, because it's a kind of an irritant for the eye. So then the small tear can progress to a larger tear. And this can particularly happen that in due course of time, the edema can gravitate to the inferior part of the cornea, which can, there are cases where like if they keep on rubbing their eyes, the lesion, the break which was smaller, can spread out, can become bigger, and the edema can increase. So if that is a situation happening, then you may have to resort to surgical intervention. So initial cases where you have very localized hydrops, very small degree of involvement, can be simply managed with medical management, and medical management will comprise of some kind of steroids, because this is an inflammatory condition over a period of time. So you will require steroids, hypertonic saline as what you specified, and also IOP lowering medication. So this would be 3 things which will be an important component of the medical management, and follow them up periodically, like 1 or 2 weeks later, and depending upon the resolution, you take your next plan of action. But if it is a large area of hydrops, then certainly one has to go for a surgical intervention in the form of compression sutures.
Thank you so much, ma'am. I think Dr. J.K. Reddy sir has joined us. So
no, I think he has poor connectivity, so that's why he couldn't join.
Okay.
Sunita, can I ask that, do you take, whenever you see a intrastromal clefts, and sometimes this DMDR, you see that it is really, there's a big gap. So you, and it is in the center, do you still want to observe, or you have low threshold for compression sutures?
So if there's a large cleft obviously seen, then those cases can benefit in a small, I take in the center part of the cornea. If that is a large cleft seen, we can take an infinity suture. I don't take particularly passing through and through the Descemet's membrane, but I pass it paracentrally like an infinity suture just to have a compression effect. So that is something for those cleft, like where you can identify a large cleft, that could be the approach. But typically for a smaller ones, I would always observe and see how the resolution is happening. Call them at 1 or 2 weeks review, and if at all it is not resolving, generally those smaller cases tend to show a remarkable improvement in 1 week's time as well. Like you will see them like improving gradually with time. So if that your response is seen, no intervention, but if it is increasing or if it is status quo, then would like to intervene with taking the sutures as what you said, but it in the form of an infinity suture to just create a compression effect.
Right. Ma'am, Radhika ma'am, if you're around, if you can let us know if you would prefer for desmetopexy air or some expansile gases like C3F8 or your SF6. What is your choice, and is a PI necessary in such cases? Or your tips for desmetopexy?
Yeah, Purvasha, I feel that like Dr. Sunita said, it is the size and the site of the tear that matter. Because like you rightly pointed out at the beginning of the discussion, hydrops is by definition a self-limiting condition. So what are we trying to achieve over here? We are probably trying to make the patient feel more comfortable And we are also maybe collaterally preventing the extent of the scar by minimizing or hastening the resolution. These are the two main aims of resolving a hydrops quickly, which will anyway resolve on its own. So if there is a small tear or an inferior tear, we can probably observe with medical management, but something larger, yeah, decimetopexy, gas obviously being longer staying than air has got a better role. And if we keep the size correct and we position the patient properly and we keep the pupil size proper, there is no need to make it more invasive by doing PI, provided we pay attention to all the factors which can kind of lead to a pupillary block. Small tears and inferior tears, for the simple reason that they resolve. And inferior, it is difficult to position the patient to get a good tamponade, may be observed like Dr. Sunita has pointed out.
Right. And your ways to unscroll the scroll DM, ma'am, if you're doing the desmetopexy, does it with the gas, does it get flattened out and buried under the trailing and endothelium later, or do they actually, is there a way to unscroll them properly?
I really would not be able to answer that because, when you put the gas, you basically do two things. You put back whatever decimex has opened up and you have, closed the opening. And whether the ribbon that is protruding can actually be, that little part which is protruding can actually be flicked back, I have really no idea.
Dr. Reddy has joined, I think.
Right.
Oh, no, he is left again.
Okay. And there's something called as fish egging of the air bubble. So it seems that also is a bad sign and you should abandon the procedure if it's not a continuous bubble. So do you have any comments on that, Dr. Sunita ma'am?
So personally for me, I am not too fond of desmetopexy at all. And I have done that in the past. And there was a time maybe we had some belief in the procedure, but I feel ever since we thought about compression sutures, have particularly just abandoned desmetopexy with any kind of gases. At the most, I would just use along with compression sutures just to delineate the level of the DM tear, because what I would like to do is I like to take partial thickness sutures and really create a compression effect. To know the level at which I'm passing the sutures, I'll just keep an air bubble at the time of surgery to just know the level, so that I'm not going through and through. And this is because sometimes you're not able to judge in very large hydrops where the tear is not delineated. Then you end up creating a taut Descemet's membrane. So you just go it within the stroma and create a compression effect. And towards the end, I will remove the air bubble. At the most, just a tiny mobile air bubble at the time of surgery, which has been put in the anterior chamber, may just remain. I'll just want to unroll, as what you said, during the procedure. But not fond of any kind of gases because they are known to cause all complications, and particularly when the tear is in the central location, in an inferior location, it does not really work, because when the patient is going to be upright, you will be actually losing that kind of apposition with the air and the site of the tear. So I have kind of abandoned desmetopexy, any kind of air, except for doing at the time of surgery, and also releasing and not keeping a chamber air bubble also along with compression sutures.
Thank you so much for your.
If I can ask her a quick question, Purvasha. So basically, the case that we saw towards the end, and also I think there is a series of published cases in the recent issue of Cornea which showed only a detachment and not a tear, which has kind of shattered my concept about Hydrops, where I believe that the progression of the disease kind of opens out the decimates and the floodgates are open and the fluid gets into the cornea, was my understanding of a corneal Hydrops. So how often do we see Hydrops with just a decimates detachment and not a tear involved at all? Do we see that? And if so, will the management be on the same lines?
Dr. Radhika, I think one fundamental thing we must understand is the Hydrops is not coming from the decimates detachment. It's actually the Duas layer, which is when it tears, that's when the stroma suddenly gets hided. That's my belief. So our traditional understanding that the decimates is the problem in Hydrops is wrong, I think. It's the Duas layer which is
detached, so that also, that also
there. And obviously there has to be a tear somewhere, not just a detachment. Maybe it's a micro tear which is not
visible. Okay.
Yes.
Yeah, I think very rightly and very clearly pointed out, because we don't see that kind of edema, sudden dramatic edema when we just have a DM separation. but it has to be a split in the Duas layer, causing that kind of profound edema in the stroma.
Correct.
Right. So going ahead with this, ma'am, there are also reports of using tissue adhesive and bandage contact lenses and thermal cauterization along with amniotic membrane graft. So what is your take on that, Smita, ma'am?
For the Hydrops,
The
I have not.
Hydrops, they are
Yeah,
reported.
yeah. So
Even plasma, I suppose.
Yeah.
Even blood or plasma, all sorts of things have been put in that picture.
Yeah, I think one of the Cornea Journal recently published about intracameral fibrin, basically because it's like a sealant, just like any kind of a glue. It is like a sealant and helps to support and kind of seal the tear. So there are reports, and I think fibrin and blood as such has been used for several conditions to seal wherever there's a leak. Even in many other conditions, anesthesia also they use that. Maybe by that principle, but I personally have not used fibrin or any such thermal cauterization for this condition, except like in the past we used to use air bubble or C3F8 gas, but abandoned completely and just switched to compression sutures, which has been working really well for these eyes.
Right. And also that we know that there are different etiologies due to which hydrops is taking place or is happening. Like example, there's keratoconus, keratoglobus, PMCD, and post-arcade. And there are post-PK cases with for keratoconus which have been done. So how do hydrops in all these differ from each other? And is there a difference in their resolutions also, or in their time to resolve? So what is your experience, Radhika?
So I have found the PMD hydrops to be the most, difficult to manage, and the one which is not amenable to most procedures, because not that I've tried compression suture in PMD, but if you do PEXI, then we cannot position the patient such that you plug the tear. And even assuming that you want to do decimetopexy, the mechanics of the tissue over there in PMD is quite different. So it will be closer to the limbus where the edema is, and taking the suture may be a little more tricky. So PMD, I feel, is the hydrops which is more tricky to contain, and probably conservative treatment works better over there.
Okay, Himanshu, if you'd like to share your experience in different types of hydrops.
I have a little difference in concept here. I may be totally wrong. I feel that it's not just about opposing the end of the Descemet membrane which is torn. It's about opposing the Descemet membrane near the endothelium, that level. How it resolves is not the Descemet is not going to heal, right? It's about the surrounding endothelium when it's going to migrate, and which is going to seal, and then it's going to secrete another Descemet membrane, pseudo Descemet membrane there, and that's going to heal. So even if you are not able, even if you are not putting a compression suture which is so tight, which one of case was shown so many sutures, even if we had put sutures which are deeper enough to opposite to the endothelial level, and along with when you stop the fluid coming into the stroma by putting gas or air. So I again would differ there from Sunita, that itself, the combination itself, would allow the migration of endothelial cell, and that seals the hydrops. And that's the same way how a normal case behaves. In fact, before compression suture, decimetopexy was done. We have done quite a few of decimetopexy. Not that they didn't work. In fact, there were enough studies which showed that the resolution time was faster than the normal resolution would occur. What happened after putting compression suture, the time further shortened. So I feel that even if we don't compress so much, if we are able to get the thing which is the Descemet membrane more towards the endothelium, prevent the egress of water from there, and allow the endothelial cell to migrate, well, that's going to heal. I want to ask one question to Sunita. Sunita, one of that case which Nandini presented, so that persistent edema inferiorly and that taut DM, we did DSO there. Do you think doing probably a blind DMAC there, irrespective whichever side it stays, or putting an amniotic membrane piece or something which can sort of block that area of open DM can resolve the edema faster, because it's been there for a very long time now, edema.
See, technically there could be many things which can be postulated to work, and anything which is going to plug the site where the fluid, where the anterior chamber fluid is egressing into the stroma should work. But then the problem is that why we need multiple approaches and why compression sutures came, we have to understand that as well. Because when you are putting air bubble, it is going to resolve, but it is going to has a potential to cause several complications like cataract. You can have secondary glaucoma, Urey-Zervelia syndrome, you'll have to do a PI, and these are young patients. So it is unforgiving to cause those kind of changes in the anterior chamber. That is the main reason why I think I'm little not in favor of using any kind of intracameral gases, because they have potential to cause trouble. Now the other thing is that when you say like intracameral gases work, they are potentially trying to bridge the gap and kind of trying to bring the edges together. And the migration of the endothelial cells is not immediate process. It's going to take time. It is a time-dependent thing.
Right.
So
That's why it takes time. That's why it takes time.
Yes. So actually, if you understand how the compression sutures is working, if we can understand how the retinal detachment heals, like we have one way of kind of putting an air bubble and causing the retina to attach. The second is the external tamponade. Now in keratoconic eyes, these are basically biomechanically extremely weak corneas. So you just put in air, you're kind of aggravating the problem. So you need some kind of external tamponade also, which is what is done by the compression sutures. And I think I am more in favor, because the kind of dramatic response in a day's time, what you see with compression sutures is just few hours time. So you can actually see the improvement happening intraoperatively. And the kind of rapid improvement happens is far quicker than any of the procedures have done in the past. So my take would be to favor that over other procedures.
I think, Sunita, you didn't get my point. I never said that compression suture are not required. In fact, I said combination of both compression suture with gas is something which I prefer, because it allows me to not put compression suture to the level where we are sort of inverting, folding the cornea to that level. So that my point was that even if we put a compression suture, and when you combine with the gas of whatever of your choice, the resolution is faster and your surface is much stable, better, and not as irregular as which we can end up in.
We had 3 or 4 such patients where we did desmetopexy. It didn't improve. Second desmetopexy didn't improve, and then we made compression sutures and improved. And as Sunita said, that even last a few months, we are also tempted to do more of compression sutures than desmetopexy.
Dr. Vikas, I have a question here. Okay, long back, I remember once, Dr. Rootman saying in the context of DSEC that when learning surgeon takes a suture to kind of, anchor the graft in the end, just a, safety kind of suture, it may work, the suture track may work like a venting incision. It kind of drains the interface fluid. So do you think that, considering the very quick improvement that you guys are having, there is a small possibility that not only the stromal opposition to the posterior layers, that fluid can be tracking to the surface and, aiding in the resolution? If there is even a doubt like that, I'm wondering if any fluorescein or any study can prove or, disprove this.
True, I agree. And Sunita already highlighted that, even during the surgery, you can see that
it seeps out.
see that there is an egress of fluid, and you see that the improvement of edema. So maybe the both the thing, the buccal effect as well as this venting incision kind of thing, both are working.
Yeah, both are working.
Thank you so much to all of you for sharing your views. Now we move ahead with the next case video by Dr. Anita Venugopalan. This is a case of hydrops in a Down's child.
Management of grade 3 acute hydrops in Down syndrome. Surgical management is indicated in grade 3 hydrops, grade 1 and 2 non-resolving hydrops with medical management. The aim of the surgical management is to hasten the resolution of corneal edema and leading to a non-vascularized scar, thereby increasing prognosis for future keratoplasty. The surgical modalities include compression sutures, intracameral gas, DALK, and mini DMAC. Here, we managed a 20-year-old male with Down syndrome presented to us with grade 3 acute hydrops with compression sutures and intracameral air and C3F8. At first, attempted direct stromal incision was not adequate for the drainage of the intrastromal fluid in our patient. Hence, a side port incision with injection of pilocarpine and air as a tamponade was done. Air in our patient has guided for the drainage of the fluid as well as identification of the DM tear. Each time the needle was inserted to suture the DM, air was injected into the AC to avoid damage to the lens. Early suture removal are indicated in these patients because they are more prone for bacterial infections. Here, in our patient, we removed sutures at 2 weeks post-op and the fellow eye C3R was done as a prophylactic measure to avoid progression in the fellow eye. So take-home message is that think of a routine procedure even in these cases of grade 3 hydrops with compression sutures. Identify the tear edges always for doing compression sutures. Early suture removal has to be done after 2 weeks in these children as they are prone for bacterial infection. The fellow eye corneal collagen cross-linkage has to be performed as a prophylactic measure to avoid progression of the keratoconus. Parents' education is a must regarding anti-allergic drops usage and to avoid eye rubbing. Thank you.
Thank you so much, Dr. Anita. And again, I think this case highlights that use of compression sutures is more convenient, especially in cases which require anesthesia, general anesthesia, wherein dermatopexy might be needed a few more times for proper resolution, whereas a compression suture might just be the thing that helps in the faster resolution of such cases, and especially in cases which also have eye rubbing and further complications like that. So, Dr. Sunita, if you could just highlight your experience with cases like these.
Yeah, so this was like I think the kind of hydrops it was almost involving the near total of the cornea. So technically compression sutures can be a little difficult to apply in this situation because you need to really identify the plane, and because it's a large area, so you have to kind of pass the sutures, and sometimes can be a little difficult to pass sutures in such a profound degree of corneal edema. So one of the ways which works is to start from the periphery in an arcuate manner, start taking sutures from one side to the other, and then the center which is there can be easily tackled. So this kind of case would take little longer time to pass the sutures to define that plane. So that would be the thing, but I think even in this kind of cases, it gives a very good quick resolution compared to just injecting C3F8 or any other gases alone.
So there could be multiple tears.
Yeah.
So there could be multiple tears which have been identified for arcuate suturing as well as the central suturing.
So I didn't understand your question correctly. You were saying
there be multiple tears. Could there be presence of multiple tears for which we are trying to suture the periphery as well as the center?
I don't think so. I think it is one common weak area which must have given away, and it must have been a large area of split which has accounted for this kind of thing, and because of that reason you see a large area of involvement. So whether it is multiple, I don't particularly think it is that kind of mechanism, because hydrops usually happens when the intraocular pressure and the cornea becomes so thin and weak that one area just splits. So it's the dimension of the tear which may be large in these cases versus having multiple tears. So it's one point which becomes weak and splits into a large area.
Right. Okay, Radhika, when is the soonest that the sutures can be removed according to you, ma'am?
I have no experience with compression sutures. I have only done pexies.
Okay. Sunita, ma'am?
I would not be in favor of wanting to remove these sutures early, only if they are particularly loose, only then. Otherwise, as long as, because it will take some bit of a time to heal. So removing the sutures prematurely can again give away, because the scarring may not have set in by then. So it should not be removed early, like no specific time, like 2 weeks, only if they are loose only then remove, otherwise not to touch those sutures. And this is particularly very true for pellucid cases because there is inferior thinning over there. If you remove the sutures prematurely, you can again have ectasia in that region. So I think it holds true for all indications of where suturing has been done for Hydrops.
But if the edema resolution is as rapid as you described, Dr. Sunita, won't the sutures loosen very early then?
In keratoconus, where if you've taken sutures and from periphery to center, in those cases I've seen suture loosening happen quicker, but not so much in pellucid. And it can happen in pellucid as well. It's not all sutures, but some sutures can become loose because it is proximal to the limbal arcade. So because of vessels, it might loosen up early. But if that is so, and if there's a large area where it is loosening early, then I would again put the sutures again, reinforce. Because you really need that kind of support until the time healing happens. So not to prematurely remove, and if at all it's loosening very early, maybe reinforce the sutures would be the best thing to consider in those situations.
I think only this case, probably because it was a case of Down syndrome, it may have been reasonable to do that because they tend to have a lot of surface problems and infections are common. But what you say makes absolute sense because the moment you remove that compression effect, it might open up again.
And Dr. Rishi, your views if there is a concomitant allergy or VKC and eye rubbing, so how would you like to tackle those cases?
You have to attack the allergy very aggressively because if they rub, it's going to happen again. So you need to give steroids and tacrolimus, whatever. You have to bring out the cavalry.
That's right. And
very true. Actually, some cases like you see some of the cases where you have active allergy, and if it's a pediatric patient, sometimes if you see the tear may be small, the hydros may be small, but 1 week the patient come with the large.
I think your internet is weak.
Dr. Sunita, can you hear us? Okay. Radhika ma'am, have you seen stromal neovascularization post Hydrops? How common is it and what are the factors that lead to it?
So basically, neovascularization of the cornea happens as a result of any form of insult. It could be trauma, it could be inflammation, or it could be subclinical inflammation like contact lens use or limbal stem cell deficiency. So in Hydrops, basically the vascularization which I have seen in very few cases is in those of peripheral tears. There seems to be a combination of the inflammation with its proximity to the peripheral cornea or the limbus that incites the blood vessel. In plain and simple central tear, however big the tear has been, it heals with kind of very thick scarring, but then it does not seem to attract blood vessels. So only the peripheral ones, to answer your question, I've actually seen fibrovascular effect rather than just a scar.
Thank you so much, ma'am. If we can play the case by Dr. Sangeeta Wagh, ma'am, for Hydrops in a case of PK for keratoconus.
I'd like to present a case of a patient of advanced keratoconus who had undergone corneal transplantation in 2004. He did well for a long time. He had also undergone a barrage laser for lattice degeneration in both eyes. He had maintained 6/12 vision in this eye. He had developed 2 episodes of rejection in the past, which were reversed with medical therapy. In 2021, he stopped the topical steroids and presented with graft edema in the lower quadrant, just as was seen in the earlier 2 episodes of rejection. He was started on intensive medical therapy, including Solumedrol, topical steroids. The graft failed to clear at 1 week, and it continued to look even more glassy and opaque. There was no history of trauma or eye rubbing. He slept with a CPAP for sleep apnea, and he was not a diabetic. Anterior segment OCT revealed a separation of the decimates from the graft host junction towards the upper end of the edema. A break could not be
noticed, and a diagnosis of non-rhegmatogenous Descemet's detachment was made. It was still a mystery as to why the hydrops occurred and what the mechanism was. He underwent a descemetopexy with transcorneal sutures and injection of SF6. He was put on topical steroids, cycloplegics, and ripasudil to lower the intraocular pressure. 2 weeks later, he reported with a blackish shadow in front of the left eye. All his sutures were loose. There was hypotony and there were shallow choroidals. There was no leak that could be demonstrated. We stopped the ripasudil, stepped up the steroids and the cycloplegics and gave him oral steroids. The Descemet seemed to be attached in the center, though it was slightly separated in areas in the periphery. The intraocular pressure improved to 24. Steroids were tapered and the loose sutures were removed. He came again with cloudy vision and the corneal edema had returned. The periphery was clear and the Descemet's detachment seemed to have recurred. Another vein attempt was made with transcorneal sutures and filling of the anterior chamber. Where do we go further? Thank you.
Thank you so much, ma'am, for sharing your case with us. Sunita, ma'am, your opinion about this case? Is it truly a hydrops with non-rhegmatogenous DMD?
Not sure what the cause of hydrops in this case was. Was it because of some kind of graft-host junction dehiscence or weakening, giving up, that kind of picture? So I'm not too sure as to what has caused that. Possibly there was some weakened graft-host junction and that has given away, but can't be really very sure.
Can I ask a question, Dr. Sangeeta? Was there edema in the peripheral graft as well, in the host cornea?
No, not really. If we looked at the very first picture, it was very interesting. There was a lucid interval between the graft-host junction as well. And there was a band of Descemet separation at the mid-periphery of the graft. So the graft-host junction was clear, the host was fine, and you just had this horizontal white band.
And did the cornea, the graft touch the limbus at any area, or was it completely?
No.
There was a click of graft, the host everywhere. I'm just thinking that maybe the fluid had found its way to the subconjunctival space somehow.
No.
And that's why whenever the edema resolved, you had something like a filtering effect, and then when the filtering effect was closed, you were getting.
No, in fact, now he's developed. I attempted a second descemetopexy with transcorneal sutures. And in fact, I'm quite horrified because I looked at the SOCT yesterday and I can see these curls of Descemes which have scrolled up at the, the central part near the pupillary border. And another very interesting thing, which actually I didn't highlight very prominently, was the development of a choroidal detachment after the first episode. And I've tried to search in the literature about the effect of ripasudil, whether that has in any way got any relationship with the choroidal detachment, because after we stopped it, we started, and in fact I had a VR surgeon take a look because I was completely nonplussed as to why the choroidal had occurred, and we couldn't find a leak at any point, and this has resolved just with conservative management. We didn't need to intervene for the choroidals at all, and there was no demonstrable leak. So it's really amazing. The only other thing I could think of is whether there is something like a pellucid that has developed beyond or in the graft, involving the graft-host junction. And like you said, maybe there was a very tiny break somewhere, which has allowed the fluid to come in. But what again is confusing is after having resolved once, why has it recurred?
Do you think his sleep apnea or his sleeping postures may have anything to do with it at all?
No, initially I thought it's maybe the mask of the CPAP that might have accidentally hit him, and that's how the whole thing started probably. But so now, to be honest, I'm really confused on what I should do next, because see, he's also depressed. His other eye has an advanced cone and I have to rehabilitate him. He's down to like 6/60, where otherwise he was independent. So my other question is, where do I go further? I know this decimase is not going to resolve. And do I go ahead with a full thickness graft, or do I attempt a DSEC or what? Because, you know, doing a full thickness graft in a patient who has had a choroidal once is again very scary, because you can have choroidals the moment you open up the eye. And if I was to try an endothelial or DMEC, I just wouldn't, because this is a large graft. And again, to get a DSEC, whether it's going to attach, or I'm really completely confused on what to do next, how to get him to be able to see.
Dr. Ashish has a point to make.
I was just curious about the CPAP issue, but how that correlates, because that's the only thing standing out here. But
so
I need to
with the
explore.
CPAP, they wear a tight mask, right?
Yeah, usually
And
it's
this
surface
guy,
issues. Yeah.
He does have a couple of pegs at night. So we don't know if he had one too many and he hit himself with the mask.
You need to do a video monitoring.
The glass or mask?
Either.
That's truly a mind-boggling case, Sangeeta ma'am.
Sharon had one such case. Sharon had one spontaneous DM. I don't know whether. Sharon?
Yes, sir. Yeah. So that was also a case which had undergone, it was an ectasia. I saw him 20 years after he had had a penetrating keratoplasty, and diagnosed that it was a keratoconus by the other eye, of course. And he actually had been treated as a graft rejection, because there was so much of corneal edema that people assumed that there was a rejection. And then when I saw him, it was very interesting to see that I could see the detached DM there. In that case, though, there was a detachment at the graft host junction. So even though it was 20 years later, it can happen. Yeah, we published this in IGU.
Thanks for sharing your case, Sharon. If we could have the opinion of Sunita ma'am, if after Hydrops, how long do you wish to wait before taking up the patient for keratoplasty?
No,
Does it have a bearing?
Yeah, again, I would wait for long, because quite often they may not need keratoplasty. So the definite waiting time will be to see how much there is. And quite often post Hydrops, when they heal, the vision is well corrected, and sometimes even the spectacle corrected vision can improve, and even the contact lens tolerance can also improve because fitting improves. So at least for about 4 to 6 months before really planning, unless there's a pressing need like the scarring is right in the center, that would be the reason to take an early. Otherwise, not a routine to do it until and unless 6 months have passed by. Madam, I had one question for Dr. Sangeeta. So you mentioned like that your patient of yours also had hypotony choroidals. Was there anything related to the lens or the anterior chamber, zonular problem or anything? Because quite often some cases which have got abnormal anterior chamber dynamics can explain both hypotony, choroidals and this kind of picture, because I mean not in peak keratoplasty eyes, but there are patients where we have seen with anterior megalophthalmos where they have this spontaneous hydrops like picture, and because of the lens and other findings associated. So was there anything of that kind in the eye to explain all that? Because it's very interesting and mind-boggling case as to why the patient should have choroidals and hypotony.
Yeah, and spontaneous. He's pseudophakic because I operated his cataract couple of years after the full thickness graft. And the thing is, the anterior chamber was deep and there was no diffuse edema. Normally with hypotony and choroidals, you see that telltale whitish appearance of the cornea with the broad folds. So the cornea beyond the area of the so-called, let's call it hydrops, or maybe the decimate detachment, the upper part of the cornea remained clear. That's how we could visualize the fundus, right, after dilating, and could see the choroidals properly. So it wasn't like the normal cornea the cornea that you see in a hypotonous eye, where there's a broad diffuse edema with folds all over. The band of edema continued to remain as such. The upper part was clear and we could see the fundus through a dilated pupil.
Dr. Himanshu, would you like comment on a pre-desmetic DALC for Hydrops? Dr. Neha Agarwal wants to know.
I just wanted to, so I would be very truthful. I have never done an acute hydrops pre-desmetic DALC. And that's why I was asking Neha that how easy it was. I would love to do, because Susan has shown quite a few time videos and those things. It will be fair on our part to try it out. But yes, of course, once it resolves, then the manual DALC does work, and that's pretty okay. But I have not. I would rather want Neha to say how was her experience with that suturing when in that case when she was referring to they had done.
Thank you so much. And Dr. Sunita, your take on endothelial keratoplasty for Hydrops, in any kind of endothelial replacement for the broken DM?
No, I don't think so. I would favor again to do that, because this is a surgery where you can, because see, the Hydrops outcome, what it's going to be eventually can be quite variable, where you may not even need a transplant. So I would rather wait and give the patient a chance and not do a keratoplasty at that stage. And there are other modalities which are working fine. Because doing any kind of keratoplasty in the type, first of all, is going to be like you don't have much good visibility. You'll end up damaging the structures in the eye. The other thing is kind of causing it will be a procedure which will lead to lifelong steroids. So I would not favor that personally myself. I haven't done also. The alternative procedures have been working fine with me, so that would be my take on managing these cases.
Sunita, since you said that after these compression sutures, it gets flattened and contact lens fitting also improves, I was just wondering, just a thought, can be weird also. Have you tried sutures in patients who have ectasia, significant ectasia, and no hydrops so far? Sutures to make it flatten, because it's working in those hydrops cases.
Yeah, no, because see, it is not very predictable. So in hydrops, we are doing it for a purpose to relieve the edema quicker. But just because when you have a clear cornea and trying to flatten is going to be far unpredictable, it won't be a very predictable outcome. What Dr. Rishi showed for and mentioned about pellucid wedge resection, yes, I've done that. But again, the astigmatism outcomes is quite unpredictable with those cases. So I've done, but it has not been very predictable approach, and that's why it's not like you do it for every case where you see a very steep, a very thin, and you plan it in a way to prevent hydrops. No, I've not done that, and I don't think it's also required to do that.
I was asking about my case, so I think I asked Sunita, but she didn't get that time what my question possible. That the case which Nandini presented post PMD hydrops, inferior hydrops, and tractional detachment, we had done DSO there, and the edema still persists. Now the thing is now to take care of that part. I feel that a small hemidemac or something, we are not talking about, and that's why I asked that can it be tried. In fact, Nandini sent one article that somebody has done hemi-DSEC there. So we are not talking about a long-term survival or something. We are talking about filling the gap with whatever we have in whichever. That's why I asked that has anybody used amniotic membrane or just plain Desmet or something to close that gap. And once you close the gap, the edema would come down and you would be able to allow the surrounding endothelial cell to possibly cover that up. So I think there's some article there. We can try it out in such kind of, again, we are not looking at long-term outcome. We are not looking at endothelial survival. We are not looking at graft survival. We are looking at closing that gap.
Himanshu, if you want to carry that forward as a very wild thought, even easier would be to try to make some kind of a supradesmetic pocket and insert a compact lenticule. That would kind of...
an excellent idea.
That would kind of handle the same issue in a less complicated manner.
Thank you. That's such a wonderful idea. That's really nice. Yeah. I surely.
That would be a beautiful outcome of this Kerakonnect series.
Yeah, sure. I think you gave me a nice idea. I think that's a great idea.
So thank you so much to all the panelists and our participants here. This was a great discussion. And we now move ahead with the concluding remarks by Dr. Vikas.
Yeah, thanks so much. And we are holding everyone back on Saturday night. It's 9:15, and thank you so much for hanging around, and it was definitely a fantastic. We had PLE, PMCD, and now Hydrops, and we are also seeing that there are many unanswered questions, and we have also we have found that the data is less. So maybe this is a time when we as CSI members, since if we take up PLE, so maybe we individually have four five cases, maybe we combine it, pool these cases, and have a bigger series. So maybe we can think of having a common protocol, and maybe we can come up with those solutions which we feel are still unanswered. Anyways, I would like to extend my sincere thanks to our panelists, because you have made this discussion so lively, and there were so many learning points. I was writing and so many things. So thank you, Himanshu. Thank you, Dr. Adhika, Rishi, Sunita, Ashish. Dr. Reddy couldn't join, but thanks so much. And thank you so much, Sharon and Purvasha. You handled it so well. And the back end, there was literature review done by Dr. Depriya, Yatri, Vishwa, and Vibha. Thank you so much. Our president, Dr. Himanshu Matalia, I had been in touch with him. He was a great support all through. Whenever I called him, he was very kind to just mentor and see that how best we can do it. So from my side, thank you so much. So we'll take just 1 minute of yours while Himanshu will say a few words, and then you are open for fellowship and dinner.
Thank you, Vikas. And it was really wonderful, Kerakonnect, to start with. The next involvement from Cornea Society would be on 1st of April, which is Friday. And we're going to start with grand rounds. We will come back with a little more detail on that, and we'll share it with you all. But the grand rounds is going to be hosted on the ocular inflammation, and Dr. Paras is spearheading the grand rounds, and she'll come back with CSI members with further details. So hoping to see you all on 1st of April, which is Friday, around 7:30 o'clock in the evening. Thank you, everybody. Thank you, office, for helping us out with this thing, and have a wonderful weekend, everybody. Thank you.
Thank you so much, everyone. Bye-bye.
Thank you.
Thanks a lot.
Great webinar. Thank you.
Thank you, everyone.
Thank you, Dr. Vikas. आपको किसी ने thank you.
नहीं, thank you so much. मैंने बोलना thank you सबको. Thank you so much. Thanks, Rishi. Thanks so much.
Thank you.
Thanks, everyone. Wonderful.
Thank you. Good night.
Thanks,
Very
Sunita.
nice.
Thank you. Thanks so much. Bye. शबीना, ये बंद हो गया?
2 minutes.
Who's there? Vinay is there, or Sheshadri is there? Who's there today?
Vinay.
Vinay, are we having the EC meeting, or we are not having? Not
No,
many
I
EC
don't
members
think-
are there?
Yeah, not many are around.
Okay.
So maybe Himanshu, we can have a EC meeting separately.
Sure. Let's have EC meetings separately, because not many people are there, and then we can possibly wind up there.
Yes,
very nice. They are very nice. So one thing we realized that I think there are people who wants to present. There are